We're going to go ahead and get started because we have quite a bit of information to cover. I passed out pre-tests and I'm about to start with the post-test evaluation. If you guys could please fill those out. There's also a separate sign-in sheet from the usual sign-in sheet. It's the one for the state to send out the CME information in 6 weeks. So if you're interested, make sure you get your name on that other sign-in sheet. There will also be a certificate of completion on the table on your way out if you want to grab one. I'm very excited for you guys to have this education this morning. The OB residents already completed theirs and they found it was very helpful for them. We have some really great presenters. Dr. Ulich is a pediatrician from Minden, so he'll be able to speak with you about how pediatricians can support moms. We have Lora Elston. She is our regional gift program representative leader. She is an IBCLC. She's going to speak about lactation management and issues. And then we have Stephanie, who is our regional WIC representative. She's going to talk to you about how WIC supports moms and how you can work with WIC to make everybody's job a little easier. So please listen carefully to everyone. If anybody has any questions about what University Health is doing baby-friendly wise, those will be directed towards me, and you will get information on that in the coming months. This is more just general lactation education and education on how physicians can support moms and families. So unless anybody has any immediate questions, I'm going to go ahead and let them get started. Okay, just make sure you find those sign-in sheets and pre-test and post-tests. Thanks, guys.
All right, thanks for having us. My name's Michael Ulich. I'm a pediatrician in Minden. I did my training at New York Medical College, and I moved down here about 9 years ago and opened up a practice in Minden from Dr. Quinones retired, and we've taken my practice from solo practice to actually we'll have 5 providers with Dr. Reagan starting in July. So we're excited to have her. Yeah, so when I first came down here, breastfeeding was just, it was non-existent. I mean, it was just really, and so even my training was not very good in breastfeeding. And then the first couple of years when I was in solo practice and sweating and am I going to kill my patients and do no harm and do the best I can, I realized the ones that breastfed, I hardly ever saw these babies. And if they got sick, for a few days of virus versus 5 or 7 days. So that's it really was a progression of rather than my experience as a young physician when I first got into solo practice. So that's why I'm really here and why I believe in it. So who else wants to introduce?
I'm Lora Elston. As Monica said, I'm the GIFT breastfeeding nurse consultant. Been a registered nurse for 10 years with a background in NICU and mother-baby. I'm also a Baby Friendly USA on-site assessor. And on a personal note, I'm a mother of 4, ages 3 to 7, and I've breastfed them all. So a lot of personal experience as well. Stephanie, would you like to speak?
I'm Stephanie Tarver. I'm the Regional Nutritionist with the Office of Public Health WIC program. I do not have children of my own, but I've been helping moms feed their children for 17 years. So I'm happy to be here.
All right. I'm not going to try to bore you guys. I know well, it's been a few years since I've been a resident, so I know you got stuff to do, so we'll try to make this as quick as possible. Obviously, conflict of interest, there's really no financial relationship that any of us will get out of presenting this. We're not sponsored by anyone besides the government. Really, the objective today is to the importance of breastfeeding and to recognize the national recommendations and policies on breastfeeding, and to help really support physicians, WIC, public education on breastfeeding, and identifying community breastfeeding resources and patient referrals, which is kind of limited, but obviously it's improved. You guys probably have gotten jammed down your throats, but breastfeeding, it's important. It's really important. Does it make a difference? Yes. These are some of the big questions that a lot of people have, and yes, it is important. It is better. There's formula. It cannot be. Is not. All the companies will say that they that they can make formula just like breast milk, and it's not true. And yes, breastfeeding is normal. Mammals have been doing it. Let's see. Some of you probably know more about milk content than I do. They're living cells, hormones, active enzymes, immunoglobulins, and compounds that can't be replicated in infant formula. And again, just to go down, put it down your throat, infant formula can never duplicate human milk. What happens today when breastfeeding doesn't occur? And here's some statistics. And the biggest ones you can see what general pediatricians deal a lot with is acute ear infections, gastroenteritis, even lower respiratory tract diseases. You can see the excess risk when we're not breastfeeding, you know. And the way you're going to have to practice medicine when you get out in the real world is going to be cost. I mean, obviously your patient's health, but this is going to be really, really important. So the government and the medical community is obviously pushing breastfeeding. Excessive health risks not associated with breastfeeding is like neck, breast cancer, among others, ovarian cancer. And obviously goes along with lowering risks if you're breastfeeding, ear infections, asthma, bronchiolitis, diarrhea, neck, hospitalizations, obesity, which is obviously a very huge problem now, and there's a bunch of other conditions. And you can see as far as if 90% of the U.S. babies or mothers breastfed, you'd have almost a $13 billion savings and about 1,000 infants saved every year just from breastfeeding. Obviously, when you talk to your parents and your moms, there's obviously lower risk for women is heart attacks, hypertension, breast cancer, type 2 diabetes. And here's another savings, so $17 billion in healthcare. So you're talking almost $30 billion, you know, from a cost savings just if 90% of moms breastfed. Then also obviously environment, that's huge nowadays, and you're talking $600 million for free infant formula through WIC, and then you can see obviously all the plastic and cans and everything else. You'd be impacting the environment also. The IOM report, as far as preventing obesity, what they said is what we're trying to promote is a baby-friendly hospital, and what that means is we really want, you know, it's when you offer a mom, you just imply that she's going to breastfeed, and that's really, really important. Obviously, reinforcing that is huge. Just to go into the excess risks as far as obesity rates, and you can look where the country was in the 90s, and you know, Louisiana is always up there with obesity, running first, and if you look at it in adults, okay, over 20% in 2000 in our area, and in the rates, look at this, in 2005, I mean, we're in that dark red there, over 30%. I mean, and if you go back as far as the breastfeeding rates, we have it here. Obviously, we're one of the lower breastfeeding states in the regions in the country. Let's see. How does breastfeeding prevent obesity and overweight? Usually hormones and other factors, metabolic differences, and self-regulation. You know, like in my hospital, you know, we're telling moms to take 25 to 30 cc's of formula for the baby every 3 hours, and you know, that's probably overfeeding. Well, the nipple from a mom's breast is going to self-regulate, so most of our babies are overfed, and we're telling them to overfeed them when they're taking formula. The national breastfeeding recommendations and policies. To reinforce it, recommend human milk for all infants, unless there's a few rare conditions, and we may talk about that in a little bit. You support exclusive breastfeeding for the first 6 months, and then really support breastfeeding for at least 1 year and beyond, and provide parents with information and resources and support breastfeeding. And that last one is really the key. I mean, you can do all that, but if there's no support from the family, the community, the culture, it's very hard to get a mom to continue breastfeeding. The Joint Commission, perinatal care, core measures. Exclusive breastfeeding includes mother directly breastfeeding or pumping, express breast milk, or donor human milk for an approved milk bank. That's impossible to get. I mean, you may be some high NICUs or high-end hospitals, but I've tried that. They'll deliver the human milk the next day. It's $300. I mean, it's just, and most of our patients don't have that kind of money. Supplementation, usually limited to medical reasons. We prefer the supplement is the breast milk, and less than 10% of healthy infants in top performing hospitals receive supplementation. And top performing hospital usually means rich hospitals. Everyone can help with breastfeeding. Again, it's really the Surgeon General's call to action in 2011 really started to try to implement this about talking about how the formula companies are marketing, maternity care practices, continuity of care and skilled support, and training healthcare professionals. The breastfeeding healthcare reform, 2010, they tried to come up with the Patient Protection and Affordable Care Act, break time for nursing mothers, reasonable break time and suitable space to express breast milk after the birth of their child, and recent laws mandate insurance coverages of breastfeeding supplies and support. Here we go. The breastfeeding rates in our area, and you can see we're in the. It's not good. It's not good. We beat a few states, but not many. The goals of the breastfeeding, as you can see, and these graphs are a little confusing. But they obviously ever breastfed, and that include just them latching on the first couple of days versus breastfeeding at 6 months, 1 year, 3 months, and exclusively breastfeeding at 6 months. And you can see where Louisiana's in the light blue, and the goal is to get us up to that brown, and we're just about 12% as far as exclusively at 6 months. I know in my region that's probably about 6%. Not even. That's double. So. There's obviously, when you're considering breastfeeding, there's racial and ethnic differences, and that's really how you grew up, what your mother did, your grandmother did, what your auntie did, and that's really going to influence your breastfeeding. And we're just going to go over the rates, and you can see the differences in racial and ethnic differences. This is a little more confusing, but it just goes over kind of the influences of what's going to influence a mother and the baby. And obviously there's a lot of influences. Let's get one. This is the one I like. This is grandmothers and friends. I think, in my opinion, those are the two biggest things that are going to keep a mom breastfeeding. And I just had an example last week, and college-educated teacher, and all her friends didn't breastfeed. And I saw all her friends' babies. Well, she breastfed, and all her friends had children that were 2, 3, and 4 years of age. Long story short, she comes in, she goes, "Well, none of my friends breastfeed, but I really want to breastfeed." And I said, "Good." I said, "Were you breastfed?" And she said, "Yes." Her mother breastfed. All the other her friends, none of them were breastfed. So those are, those are the two big factors that I see. Father's opinions, yeah, but really, in my opinion, grandmothers and friends, it's the father says, oh, shut that baby up at 3 in the morning, stick a bottle in their mouth. And you just got to really, and the problem is a lot of the dads don't come in. So when you're sitting there and I call it the Tony Robbins, when you're trying to motivate them, that father's not there. So, you may get that mom, but she's got to go home to that husband or boyfriend, and he's got to get at work in the morning, and he just wants that baby to be quiet. So it's really, really important. Who can breastfeed? Obviously I can't. And I got the long hair, but everyone, you guys know more about this than I do. This is more just anatomy stuff. And let's see. I think we're going to hand this over. Who's got? You have questions for me? I'm going to come back in a few minutes and talk. Anything urgent right now? All right. No questions. Coffee.
Yeah. So there are, a lot of women have concerns about, can I breastfeed? Why shouldn't I breastfeed? And these are some of the most common concerns. The first one is fear that it's going to hurt. And unfortunately, there are a lot of stories out there. A lot of people say, I've heard it's awful, it hurts so bad. And that's really not the way that it's supposed to be. And then we'll talk about the correct latch, and that's going to prevent the pain. Then the biggest concern that I see as a lactation consultant is that moms are concerned that they're not going to have enough milk or they're not making enough milk. And we're going to talk about the infant stomach size and how the production of breast milk works. And then we also hear moms talk about their babies being fussy, and a lot of the time it's just because they don't understand the normal baby patterns, and they worry about breastfeeding taking too much time. They feel that if they formula feed that they're going to save themselves times, and then they also worry that they're not going to get enough sleep, and they think that if they formula feed that they're going to get more sleep. So we're going to address a couple of those common concerns. The first one is we're going to talk about a correct latch, and especially you guys going to be out in practice and making your rounds on patients in the hospital. If you don't understand the anatomy of a correct latch, it's very difficult to help a mom when they're seeing you and asking for questions. So talk about that real quickly. The first, you're going to want to make sure the baby is positioned correctly. So you want to make sure that mom and baby are belly to belly. So you'd be surprised that mom's trying to feed their baby's belly's turning out this way. That's uncomfortable. I mean, if you turn your head and try to swallow right now, it's very difficult to do. So belly to belly. Then you want to make sure that mom and baby, that they're lined up correctly. So you want the baby's nose to line up with mom's nipple. So think nose to nipple. And then we also want to make sure that the baby has a very wide open mouth. So you want a big, almost like the baby's yawning. And then you're looking for something called an asymmetrical latch. So years ago we used to tell moms just to do kind of a straight centered bullseye latch. Now we're saying asymmetrical latch. So that means that the top lip is going to be closer to the nipple than the lower lip. So does that make sense? Asymmetrical latch or all-centered latch. And that's going to promote a deeper latch. And then when mom is breastfeeding, it shouldn't be painful. The initial latch on, especially that first week, may be a little sore or tender, but the entire feeding should not be painful. And if it is, then that's not a correct latch. And then you want to show the mom to notice those good rhythmic suckings. So again, we're going to talk about the size of an infant's stomach, and Dr. Ulich talked about how we overfeed our babies. And we just need to help moms to understand the size of a newborn infant's stomach. So on day 1 to 2, the stomach is only about the size of a shooter marble. So that's really only 5 to 7 mils. So that's very tiny. And that's why we see, those of us who've worked in the nursery, we see a lot of babies formula feeders throwing up, because when you're giving them 2 ounces, what do you expect them to do? They're gonna throw up. And then day 3 to 5, the stomach grows to about the size of a golf ball, and by day 10 to 14, then they are going to be having the 1 to 2 ounces that they can hold during feeding. But the great thing is that mother's milk meets the infant's needs. So the breast, when the baby's first delivered, hold about a teaspoon of colostrum, and that's going to be the first milk that the baby gets. The colostrum is the milk that's going to be high In protein, it stabilizes the blood sugar, and we like to call it, in the lactation world, we call it liquid gold. And it's also important to note that the composition of the breast milk, it changes throughout the day, but it also changes with each feeding. So you have foremilk and hindmilk, and this is an important thing to discuss. It's why we don't want to time feedings. So at the beginning of the feeding, when the baby first goes onto the breast, they're going to receive a foremilk, which is more of, I think of it like as a watery skim milk. And then towards the end of the feeding, they're going to be taken into hindmilk, which is a fattier milk, or think of it as a whole milk. So if you tell moms to only feed their baby 10 minutes and then switch to the second breast, that baby may only be getting the foremilk, and that's the baby that you're going to have that's not gaining weight well. So you want to let the baby finish the first breast, let that baby, and when they're full and pull off the breast, then you can tell the mom to go ahead and offer the second breast. So I always think of it, main course, offer dessert is what I teach moms. And that way the babies are going to gain weight better. So even if a baby's only nursing excuse me, a one breast of feeding, that's okay. But that's why we don't want to time our feedings. And supply and demand, so the more the baby goes to the breast, the more the body is going to make breast milk. And so teach your moms that they have to let the baby put the order in for the breast milk. So every time the baby goes to the breast, your body's going to produce more milk. And I'll have moms come to me and say, I don't feel like I'm making enough milk. Well, how many times are you putting the baby to the breast today? 3 or 4. Well, no, you're probably not making enough milk because you're not letting your baby breastfeed whenever he's hungry. And we need to teach our moms to feed their baby 8 or more times in 24 hours. And so I like to say 8 or more in 24, kind of get that stuck in your head, 8 or more in 24. And we want to teach our moms that feedings are not going to be evenly spaced. So I know when I had my first child as a NICU nurse, I was very much every 2 hours, every 3 hours. And when my son was wanting to eat every 1.5 hours, I was like, no, you're not. but I did, because that's what he needed to do. And so you need to teach moms that their babies aren't going to be on these perfectly schedules like their friends who are formula feeding are. You're going to have to let your baby feed when he or she's telling you, and it's not going to be every 2 or 3 hours. And that the babies will cluster feed, so they might have a time during the day where they're going to want to feed back to back, and they may go a little more time later on in the day. And we also want to teach our moms that early formula supplementation and bottle and pacifier use can actually interfere with breastfeeding, and it can affect your breast milk supply. And we're not trying to be mean when we say, oh, you can't have a pacifier, but we know that when we start giving babies pacifiers, that's going to change the way that they suck on to the breast. So they're going to try to suck at the breast like they're sucking on a pacifier, so that's going to damage mom's nipples. And also, if a baby is wanting to suck, they need to be going to the breast and not being, quieted or calmed using a pacifier. And obviously, AAP does recommend pacifier use at 1 month of age. So that's after breastfeeding is well established. They can use a pacifier. This is addressing the amount of time that it takes to breastfeed. So you have the red line, which is the time to breastfeed, and then you have the blue line, which is for bottle feeding or formula feeding moms. And yes, initially it does take more time for the mom, time spent breastfeeding, but you can see by week 5 it starts to actually decrease, and so it does actually save time in the long run to breastfeed. And that's, you're not having to get up and make the bottles, you're not having to wash the bottles, and so it's an investment that's definitely worth it in the long run. And then addressing the issue of not getting enough sleep, you have 3 different columns. You have breastfed infants, formula-fed infants, and mom that do both formula and breastfeeding. And as you can see, it's really all about the same amount of time, amount of minutes that a mom can sleep. And it's not breastfeeding that takes the time, it's just being a parent. You're just not going to sleep, and you just kind of have to get used to it. So you can just help your moms understand these things. All right, I'm going to turn back over to Dr. Ulich.
Well, healthcare strategies and breastfeeding support. You know, when you're guys in residency, you have your continuity clinics, and I don't know how, you know, what you guys are implementing in your continuity clinics, but obviously consistent message and support. And I was talking with, before that really it has to start the day that mom knows she gets pregnant and goes into her first prenatal visit. And I guess she gave this lecture to the OB-GYN residents last month. And I was like, it's got to start there, because there's great OBs in my town, but they're kind of older school now. Well, the guys that were there before, now we got some younger doctors there. But you know, it just wasn't when those doctors were in training. It just wasn't implemented then. I mean, I'm 41 years old, and I don't know one of my friends that grew up that was breastfed. I mean, raise your hand. Who was breastfed here? All right, okay, and I bet you most of you, well, there you go. I don't say older guy, but most of you probably are under, you know, 30 years of age, and, you know, so it became really popular because there was a stigma about it in the 60s and 70s, or really the 70s, that if you were breastfed, you were poor. You know, so, oh, you got to buy this great formula. And all my brother, I had two older brothers, and we were all bottle fed. So, you know, it's a generation, but we obviously realize that breastfeeding is best now. And this just goes more into clinic stuff. You guys will, some of you that are getting out, you know, it's just a matter of just being part of your practice and making it part of your staff and nursing so as you can see here, are you talking about breastfeeding? Well, most pediatricians and family practice doctors are not. Less than 1/3 of any visits, including a breastfeeding discussion. We talked about starting the conversation sooner. Avoid asking bottle or breast. Just kind of put it out there, like, you know, you're going to breastfeed, right? And then let them kind of come back and you say, no, I want to do formula. And this way, this will start the conversation. And then you say, why? Well, I was bottle fed and I was fine. And you know, well, I'm going to go back to work in, you know, 6 to 8 weeks. And you're like, well, okay, but we can come up with strategies that you can, you know, and there are a lot of employers now that will allow for breastfeeding, but they have to ask. They're not going to just, you know, because I'm an employer and I know how that is. It can be time consuming and take away from productivity. The employer thinks that, but if we'll go over some statistics later to show no, that actually decreases sick visits and time off by mothers. To go back, did she breastfeed before? If she did not breastfeed baby, have you considered breastfeeding your baby, the second baby? And I use my own example. I had a mom about 6 years ago, and she was in her early 30s, and she was on her 4th child, and all her 3 children had bad skin. They were atopic type kids, asthma, and they were all bottle fed and went through 5-6 different formulas on, you know, the doctor that was there before me. So I finally convinced her. I said, we're going to breastfeed, and she trusted me because I was taking care of her other children, and we did it, and that child did great. Now I can't say that's every case, but I mean, never had a skin problem, never wheezed, was one of my worst wheezing families, and it was the same daddy, same mommy, as far as we know anyway. Yeah, it just shows that and now she's like one of my biggest promoters, you know, and that's where that culture can change. If you can change a few people in your community, they will be actually promoting it, and then it'll get out into the general public. Prepare families for evidence of base hospital practices. This is what we're kind of doing with the baby friendly and the gift program. Skin to skin, rooming in, unrestricted cue-based feeding, exclusive breastfeeding, having support staff, and that's really where you find a lot of resistance in hospitals, because nurses, you guys know, they're busy, they got all these patients, and you know, sometimes they have to sit there for a half hour, 40 minutes, and try to get this baby to latch on and really motivate this mom, and it's a lot of man hours. So you know, it's a lot of, and it has to, you know, it's got to come start with us and go down, and really, you know, I always say the nurse can say whatever they want, but if they say the doctor said it, it just seems more important, even though they're saying the same thing. So that's when you guys get out into private practice, you'll see that doctors thing usually can go a little more, not all the time. So skin to skin care, as soon as they come out, put them on. We actually don't even take their temperature. They just go right there, unless there's something clinically wrong with them. They go right on there, and a couple hours they're skin to skin, and then we'll take the baby in. They'll usually breastfeed first, and then they'll take them in. We'll wash them, get their vitals, get their weight even. We don't even do weight. Usually the baby comes out, we weigh them, and then they'll go to the mom. We don't even do that anymore. We just, you know, unless they're, you know, some sugar issues, or they're, you know, LGA, SGA, or obviously preterm. Yeah, so that's early cues: stirring, mouth opening. Make sure I always go over onto the other ones. 56. Yeah, I think you keep going. Okay, that's fine. I don't mind talking. Keeping mother and baby together helps mom with the stress. You know, she just had the baby, either vaginal or C-section. Baby's less stressed, and so these are a lot of these postpartum strategies. Asking open-ended questions. That's really, and you guys, you know, you have really good attendings, and you know, just ask one question and let the mother go to town, and you just guide them on the way. But that's really key, because if you sit, I always say, sometimes it's good to be a male pediatrician, and sometimes it's bad. And I see my female colleagues in town, you know, they've all had kids, and most of them are breastfed. But when sometimes, not all moms, it just depends, you got to know your patient well, but when you say, well, when I breastfed, I did this. Well, you're not you. You know, they're not you. So it's, but then they're like, well, if I'm saying, well, I've never breastfed, you know. So it can go either way, and I've seen that. And it's just, so that's why that open-end question will say, and then, you know, I usually say, well, if they ask you, especially as a female pediatrician, then you can give your experiences. But if you just come out and say, well, I breastfed this is what happened. But as we all know, you know, not every child and mom and breastfeeding experiences are the same. So it's okay. So our role is to evaluate, manage, and you say, well, you know, do I need to start supplementing with formula? Is the mom making enough? So our job is to really kind of reassure, look for fussy baby, weight assessments, jaundice, latch problems, mother's milk supply, and breast and nipple discomfort. And as a pediatrician, you're going to see, and like I said, I really didn't catch on till about 3 or 4 years into my practice, was these moms would come in with sore nipples, okay? Now, they were latching on fine, and you know, I would find out that I'd get them some nystatin and put it on their nipples, and then let the baby breastfeed, and they'd have almost subclinical thrush. I mean, they didn't have white on their, and then a lot of moms will have underneath their nipples, they'll be cracking, they'll be a little fungal, and you put them on nystatin in about 3 to 5 days, the nipple pain goes away. And because then they'll start to quit. They'll start supplementing because it's hurting too much. So I've seen that quite a bit, and it's worked out pretty well. Obviously, jaundice, breastfeeding from jaundice. You always tell moms, the moms that know about it, hey, your baby's going to turn a little yellow, lots of sunlight. Keep working on the breastfeeding, and breast milk jaundice obviously is not dangerous. It may persist for weeks, and I don't know in your experience, but I always tell them, because his eyes still yellow, and he's, you know, the little baby, you know, the baby's 10, 12 days old. Well, jaundice usually starts in the face and goes down to the feet, and as it gets better in the feet, and the last to go is the face and the eyes. So you kind of explain that to him. So, oh, okay, so his eyes still can be a little yellow at 2-3 weeks of age. Obviously, he's gaining weight and getting back to his birth weight. Late preterm infant feeding problems can be related to prematurity, weak suck, low tone. That's when you're gonna do some syringe feeding may help. You can have obviously potential delay in lactogenesis because of the prematurity. Medications in breastfeeding. What's great, most people have iPhones now, and everyone's, oh, can you take that? And so there's a lot of resources for us, for physicians and nurses, about what moms and moms cannot take while breastfeeding. But most medicines moms can take. There's a few that they can't, and I don't always remember them. But I got what is it, the LacMed one, which is great. You just get it on there, but you will have, what you'll see is you'll go and they'll go to the OB and get treated for mastitis or put on antibiotics, and then they think they can't breastfeed anymore. And it comes back to the OBs again and say, oh, no, you can't breastfeed. And then boom, they quit. And most of the time they can still breastfeed, or sometimes they have to pump a little and dump, but they usually do pretty well. First maternal care visit, assess the breast and breastfeeding as needed. This is really, what I've seen is I have a nurse practitioner and I'll go in and, I mean, you may be in there for a half hour. Well, suppose you got 10 minutes with this patient, right? So you just got a team effort. I'm like, and she was she breastfed and she was a lactation consultant. So I'll say, listen, you take her. I'll go in and assess. I said, you go show her some tricks of breastfeeding, and then I'll go and see her patients, and then so it's really a team effort. It just depends on how experienced you are. I mean, I'm good at doing it now, and some moms are not comfortable with the man there, but some are, and it's fine. It's just very time consuming at times. Again, open-ended questions, back to work school issues. Really talk about pumping, and what I usually recommend. I said, the first 2 to 4 weeks you don't want to pump at all. If you're gonna pump because you're just engorged, and you'll save it, put it in the freezer for a rainy day. And you gotta really educate and say because a lot of moms, they have a baby and like, all right, the hard part's over. It's just beginning. I call it the 2-week hump. I probably should use a better word than that. But if you can get over that 2 weeks of getting used to your baby and breastfeeding and being tired and hormonal and everything else, usually those moms that can get over that 2 weeks of strictly breastfeeding, they do very, very well. Working moms, type of work sites. I think Louisiana, it's over 25 employees. They're supposed to have a breastfeeding area. But if the mom doesn't ask, the employer's not gonna volunteer a breastfeeding system for that work. Pediatric 2 to 4 month visit is about delaying complementary foods. Latche League, all those, they say 6 months. I'll say, hey, if they got good neck and support and you can't keep up, it's okay to start some baby food and cereal at 4 months of age. Obviously the longer you can breastfeed exclusively, but some moms just can't keep up. So usually 4 to 6 months is when we recommend. The earliest 4 months of age. Try to get them to 6 months. Here we go. Talk about mastitis, gastroenteritis, UTIs, vaginitis, and so these are all things mom can breastfeed through. But for some reason, a lot of the OBs, I'm throwing them under the bus today. They tell them they can't. And about an older child, perfectly normal. Like I said, this is about a culture thing. And men are partially to blame for this, because well, I don't want my wife out there breastfeeding in public. I mean, some guy's gonna look at her boob and try to sleep with her. I don't know. So it's really it's absolutely ridiculous. Breastfeeding during pregnancy, normal pregnancy, healthy mother. It's a personal decision. this is the biggest thing that we find in my office now that we've kind of implemented, and the hospital at Minden Medical Center, is knowing your community resources, and this is really the key right here, and that goes from they started the Louisiana Breastfeeding Coalition, and prenatal hospital and postpartum resources, workplace breastfeeding, and training for child care providers. Tell me when I think I went over.
You're just right.
All right.
Nope. Perfect. Do y'all have any questions right now? Anybody? We're almost done here. I know you guys need to be going to clinic, I think, at about 9 o'clock-ish or so. But yeah, so the Louisiana Breastfeeding Coalition, which is actually one of the organizations that is supporting this training today, it exists to give resources to professionals and to the community. One of the things is the Workplace Breastfeeding Support Program. They also keep us up to date on legislation. And speaking of legislation, just so you know, and you can tell your moms as well, that it is legal for any mom, anywhere a mom can be, a baby can be, they're allowed to breastfeed. And also child care centers cannot discriminate against breastfed babies. And then there's some, the school boards have made also some laws to help breastfeeding moms. So in Louisiana, we have a breastfeeding initiative, a hospital initiative program called the GIFT program. And what it is, it's a program designed to get hospitals to implement evidence-based breastfeeding and maternity practices. There's actually, that says 25 hospitals in Louisiana, but there's actually, we just got our 26th one. And we provide, and that's part of the group that I work for. And we provide technical assistance and training, and we're really encouraging hospitals to go baby-friendly, which University Health Shreveport and Conway are both on the baby-friendly designation journey. And that's something, especially you guys as new pediatricians are going to probably hear a lot more about baby-friendly. And what that is, it's a UNICEF and World Health Organization initiative. And that was created back in the late 80s based on the 10 steps to successful breastfeeding, and I'll tell you what those are here in just a minute. But worldwide, there's over 20,000 hospitals that are baby-friendly. In the U.S., there's 240 now. And as of February, Louisiana has 5 baby-friendly hospitals, but the closest one to us is Opelousas General. So we need to get some more baby-friendly hospitals in the north part of the state. The 10 steps to successful breastfeeding: number 1, that there should be an infant feeding policy. Number 2, that staff and physicians are trained, breastfeeding training, and that's why you guys are here. You can't promote breastfeeding or help with breastfeeding if we don't really understand it and understand how to provide women support. We need to educate moms about breastfeeding prenatally. Skin-to-skin care immediately after a vaginal delivery and breastfeeding initiation within an hour of birth. And we need to help with breastfeeding assistance with positioning, latch, and expression. I hear some pictures going on. And step number 6 is to support exclusive breastfeeding. So we're not going to supplement unless there's a medical indication. Number 7, I really want you guys to look at this one, rooming in of the mom and baby, and where you guys, this is really going to affect y'all, is traditionally pediatricians, they get all the babies corralled in the nursery for rounds, and there's really no need for that. I mean, a baby shouldn't be sitting in a nursery for 6 hours, and that's taking a baby away from mom. The baby's in there. They're usually showing feeding cues, and the nursing staff, we keep going over there trying to calm them down. But as pediatricians, you're going to be going to the parents' room anyways to update them. So it's really not going to take you more time to go do those rounds and do those assessments in the mom's room. So really remember that as you start your own practices. Number 8, early feeding cues, so teaching moms to feed on demand. Number 9, avoiding those pacifiers and artificial nipples in the beginning for breastfed babies because it can interfere with breastfeeding. And number 10, community breastfeeding resources. So those are the 10 steps to successful breastfeeding. That's what all this is really based on, the evidence-based breastfeeding and maternity practices. Just quickly speak to this. We also have an expanded initiative in the state that we have some extra funding and resources. We have the mobile app, which can be, you can go to the App Store, you can download it at cofective.com, which is going to help educate healthcare providers and actually help educate staff. And Monica, do you want them to go ahead, if they can, to download this app, start looking at it?
Sure, if you guys are interested, this is a fantastic resource for you to keep on your phone. You can use it on a tablet to directly educate parents. It's built for that, but it's also built to allow the healthcare provider to explore all the parts of the site that we're using to teach mom. This is the education that all of our patients will start getting in the clinic and in the hospital. It's all color-coded, it's built the same, says the same messages, so it would be good for you to understand the things that we're telling the patients.
So there's just some examples of the mobile app. Also, the patients will start getting in the clinic, it's called a We're Prepared checklist. It's just prenatal education, trying to get these moms to start thinking about breastfeeding, skin to skin, rooming in, trying to get them to understand those practices and why they're important before they get to the hospital, because unfortunately a lot of times when a mom, she comes in labor, the decision is made. You know, I could go in there as a lactation consultant or a nurse and I could speak to her till I was blue in the face, but at that point she's made up her mind, so we need to try to get her educated on breastfeeding before she arrives. And then these are the counseling sheets that are also going to be used in y'all's clinic or and at University Health, the counseling sheets that can be used at the bedside to explain skin to skin, rooming in, not supplementing, all these great things, and they are color-coded as well. And we have some leave behind materials that Monica has, some great resources. Something that y'all should think about as well in your when you go into your own practice is what message are you sending about formula feeding? You know, formula reps, they're not bad people, but they we want to, you know, sometimes they come and they offer us free lunches, sometimes steak dinners, and we think, oh gosh, these people are so nice. But the reality of it is they are using us as free marketing agents. And so be careful about that. And in your offices, do you have formula coupons laying around? Is all the growth charts or all the charting documents that you're using, is it have formula logos all over it? I know my personal life, my kid's pediatrician's office, great, probably the most popular pediatrician in Bossier Parish. So I walk in and then there's this huge wall of formula, free formula. And the formula companies, you know, they tell the peds to give that stuff out. And so what message does that send when you come in and you're telling these moms breastfeed, breastfeed, but then they come to your office and all they see is all these formula logos. So be careful of that. Think about the message that you're sending. You can bill for some breastfeeding support. AAP has a good document on that. Let's get past that. Also be aware of what a IBCLC is. That's the certification that I have, which is International Board Certified Lactation Consultants. And so if it's something that you as a pediatrician feel you need, you know, this is kind of outside of your scope, that's okay. Feel free to refer them to the hospital lactation consultants. There's 2 now here at University Health Shreveport, and there will be 1 in the clinic, staffing in the clinic.
Are 2 that are employed in the hospital. We'll start covering clinic days probably in 2 weeks. They'll be in the clinic at least 2 days a week, servicing both the prenatal and the pediatric clinics. So you'll get more information about that in the next 7 to 10 days.
Yeah, and most hospitals do have somebody there that specializes in breastfeeding support. So find out who that is and you know, feel comfortable referring your patients there. Just remember that a breast pump cannot tell a mom exactly how much breast milk she's producing, because even the breast pump is not going to get as much milk out as the baby is. All right, I'm going to let Stephanie speak to the WIC program, and we are just about done here.
Good morning, everybody. The WIC program, most people, when they think about the WIC program, they think, oh, that's who gives out the formula. But we are working really hard to change that perspective, and we are promoting breastfeeding with all our pregnant women. Everybody who walks in the WIC clinic as a pregnant mom receives nutrition education and about breastfeeding. We also have a peer counselor program, which is other WIC moms who have also breastfed that are sending, you know, making contact with the new pregnant women to say, hey, yeah, I did this is great, this is awesome, you can do it too. Dr. Ulich alluded to the fact of support, and that's one of our biggest struggles, is if grandma doesn't support it, dad doesn't support it, then mom gives up. Because we're doing really great at getting moms to start breastfeeding, but if they don't have that support at home, it starts to fall off. So I think of all this, that with the moms, the biggest thing is the support. And real quickly, we also tell moms, if you breastfeed, you get the exclusive breastfeeding package. You get the Grand Deluxe WIC package. It has the most stuff on it and food on it. So we do everything we can to get moms to really work towards it. We have, actually, Louisiana has gone from being last to like 45th maybe, instead of 50th in our initiating of breastfeeding. So we're making strides. We just have a long way to go. And with your support, that will help us to continue. If we work together, I think we can really get it going. So that's it.
There was a picture of a pump. Do you want to talk about the pumps? What pumps are available on the food package one? Because you'll probably have a lot of moms requesting breast pumps.
We do have breast pumps available at WIC. We have hospital grade pumps that they don't really rent. They don't have to pay for it, but we have to bring them back to us each month. But we also have personal pumps that once they give them to them, it's theirs. Pretty much they just have to request it from us, and we assess. We always promote skin to skin, latch on. You're the best pump there is. So but we will give them an electrical pump.
You give them pumps like that first, like if the baby's a week or two old. Like my WIC office usually at a month, so the mom's got to show that she's breastfeeding.
We really, the policy has changed. Okay. The policy used to be that you had to be returning to work or school before we would give you a pump. And some of our WIC sites still have that in their brain, but actually our policy is that we can give it to you anytime. But we really, really encourage that you establish a milk supply by letting the baby latch on. And because we also find that we give a pump too soon, they're back in a week saying I'm not doing it anymore, and then there's that pump we can't take back. Yeah. So, but yes, we technically can give them a pump at any point. Yes. Anybody else have any questions?
Okay, so from all this, what do we want y'all to know? Number one, we want you guys as healthcare professionals, as physicians, to make a commitment to the importance of breastfeeding, to really understand the superiority of it as far as compared to formula. So really make that commitment. Train your staff in the skills that they're going to need to support breastfeeding. Keep yourself educated. And things change with breastfeeding literature and information. So I worked with, I love to tell a story about this pediatrician. He was 84, still practicing full time. He thought he was the best breastfeeding advocate there ever was. But unfortunately, some of the things that he was teaching and telling moms was really setting moms up to fail. So really make sure you stay current and up to date with what you're teaching about breastfeeding. And then make sure that you tell moms about breastfeeding benefits. Continue to encourage feeding on demand, and the main thing is just supporting the moms and really helping them to understand that this is what they need to be doing, and this is important, and that it is worth it for all the hard work that they're going to put into it. Okay, that's all that we have. Do you guys have any questions for us? No, it's kind of a lot to take in. Yes, sir.
I must commend you all for educating these young pediatricians on. I'm coming to you not as a pediatrician neonatologist, but also as a parent or grandparent who's seen our kids struggle with breastfeeding and succeeded. Nowadays they get all the information on the web or apps. The question for you guys, your number of 6%, by quoting you right, told me. So are you all keeping track of it? What is being done?
We really can only keep track is when they leave the hospital. That's it. Now, in private practice, if we had some more, like EMR would be great if all the computers could communicate with each other. You could say it'd go back to the hospital would send it to the state, and the state would have the numbers.
The state, yeah, that's right.
Yeah, so those numbers are really hard to keep. What most of these statistics are either a survey done in the office, or when the patient leaves the hospital, they're breastfeeding. The baby's breastfeeding.
So that number.
And then you lose.
Lower.
That number is probably lower.
Much lower because it's well known that the attrition rate is high. But anyway, as you rightly pointed out, the two factors are culture, social culture. I do quite a bit of global health, and I see every mother's baby has got skin-to-skin contact, whether it's in the NICU, whether it's in home ministry. But anyway, so what is being done in the community, those of you who are being in the community, to educate the churches and the community leaders?
Well,
this is nothing new. What appalled me also was that the La Leche League in Louisiana is disappearing, not disappeared, because they were a great support system. So
the hospital, Minden Medical Center, they have you know, these breastfeeding classes while moms are pregnant. You know, when you have a certain population, and I have a big mix of poor and middle class and some rich, we almost have to be paternalistic. Like, especially if in my opinion, and someone can disagree with me, it's fine, but when you're having someone that is getting formula for free and a lot of these things for free, you almost have to say, all right, if you want free formula, you have to come to a breastfeeding class during your prenatal visit. Okay, I mean, this is not communism, but you know, you have to come. I mean, Willis Knight does, if mom wants an epidural, they have to go to an epidural class. They have to go to an epidural. If they're not going to get it. So why can't we implement those in our community? Okay, at least one time. You got an hour, maybe you can convince people. So, you know, from a pediatrician's point of view, when I was in residency 10 years ago, I came down to this small little town in North Louisiana. You know, I had a good training in sick kids. I could recognize Kawasaki's and blah 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 blah. And I was like, all right, I'm gonna, you know, be the you know, the fighter pilot kind of thing. And in reality is, yeah, I've caught a few weird cases in my day, but this is going to be my biggest impact, our biggest impact on our country. And I felt that my training as a pediatrician didn't really address that, and I really learned that the last 3 to 4 or 5 years in private practice. And I said, this is going to be my biggest impact in this region, and then if everyone gets on board, I mean, so that's, you know, but you're right, the community is really, the churches would be a great place also.
And if I may, Dr. Ulich, that's a significant portion of the strategic plan for our Baby Friendly initiative. If you listen to the steps, step 10 is to foster the creation and to support community organizations that help moms and babies, and that we're actually focusing a lot more on that piece than a lot of hospitals do, because we have zero community support for our typical patient population right now. So we're working hard to make support groups for fathers, support groups for teen mothers. We're carrying the Baby Friendly initiative through our faith-based community health initiative into the churches. We are using our rural health initiative to carry it out into the clinics in the areas that may not get directly serviced by us frequently. So we're trying to spread it through the community a lot more than most hospitals do, because I think in this area, like Dr. Ulich mentioned, we have the potential to make a huge impact. We are arguably one of the poorest performing areas in the nation on every single breastfeeding measure, every single one. Our patient population initiates the least. They have the least in hospital exclusivity. They have the least number of babies still breastfeeding at 3 and 6 months. We really have the ability to make a very broad impact in the health of moms and babies grow up to be kids and be adults. And if they stay here, we can make our population a lot healthier by getting these babies breast milk in the beginning.
Don't we have one of the lowest rates in Louisiana?
We do. Caddo Parish has the highest rate of premature birth, one of the highest rates of low birth weight infants. We also have one of the lowest rates of breastfeeding initiation and duration and in hospital exclusivity. So if you consider the interplay of all those things, we really are in dire need of some support for these moms, and it starts with us. That's the whole idea, is that we can be the foundation for a strong community web.
We're developing a network of, you know, people that our mothers can call, and that we feel is the way it's going to extend it out. You know, if you're having problems, call one of these ladies. They'll be glad to talk to you. And we're looking at some other apps that will send text messages periodically to breastfeeding moms that just, you know, enforce the, you know, the importance of it. So we're looking at several things, but the mentoring program is really, and we have several ladies that have breastfed and they're really bought into it, and we'll probably get in touch with the one that Dr. Ulich was talking about, but that we feel is the way that we're going to, and have them connect with the mentoring program before they deliver.
Yeah.
Because you need to have a relationship before you get in.
And then the reality of practice is, yeah, I'd love to see 8 patients a day. You know, 45, you can't, I don't care if you're in private, you're all private insurance or Medicaid, you can't do it. If you own a practice, you can't do it, and if you work for someone, you ain't gonna last too long in that practice. So the reality is to get some system like we talked about where you can, because you're going to spend that 15, 20 minutes, maybe a half hour, but you can't spend 45. It's impossible. The system does not allow for it.
You have to support the system.
Right. You have to support the system, initiate it, but you know, it's got to come from us, and you know, that's why we're doing it.
I guess in the interest of time, we have to close this conversation, but I think this has been a really good presentation. I think it's clearly there's a strong commitment for improving breastfeeding within this state, and the importance of it for each mom and every baby. And so I think together it sounds like we've got a very strong effort to try and improve things, and I think as primary care providers, this is going to be all of our jobs, and I think it's really important. I think woven in this presentation, you've heard a lot from Mike about how to be successful as a pediatrician and how to build a practice where you pay attention to each of your patients and recognize each of their needs and develop what you need within the practice to kind of support that. And I think that's really good. And so I think that's a good message on top of the breastfeeding message. So thank you all for coming. Very helpful. Thanks.